this opportunity, I take Dr. Gautam to giving me an opportunity to give a talk here. So now we are again back to endometrium. Now there's going to be a bit of repetition of the concepts and slides. So I would be emphasizing or talking more on the things which have not been already taught. A patient will ask, why did my IVF cycle fail? How many times are we faced with this question? I would say very often. Every fifth or sixth patient walking in our OPD is going to give us this brain-racking question. Whether we have an answer to it or not, we are definitely answerable. So, since the introduction of IVF, there has been innovations on induction, retrievals, fertilization, freezing, but a big lacune still exists in understanding the implantation process. 2/3 of the failures contribute to endometrium and 1/3 to the embryo. We know that the successful implantation requires a very receptive endometrium, a functional embryo, and a synchronized dialogue between two. So, understanding what is the implantation window, when it begins, when does it end, and also understanding what synchronization happens on the morphological, the molecular crosstalk between the two, the participation of the growth factors, and also the involvement of the immunological factors. We have to basically understand the markers of endometrial receptivity, which include the biochemical, structural, and on ultrasound, because once all these things you have been ruled out or on track, will keep you and your patient on the proper stimulation and helping to transfer a very good embryo. For endometrial receptivity, if we can strategize, so if we develop 4 strategies, first is to develop the ovarian stimulation protocols. Second is to avoid the endometrium which was disturbed by high dosage of gonadotropins. Thirdly, to increase the uterine vascularization and to treat the pathological conditions of the endometrium aptly. Clomiphene citrate, I think there's no point in elaborately talking about this, because by the time the patient reaches you, almost for maybe more than a year and a half, the patient has already taken clomiphene citrate. We can advocate the use of GnRH antagonist protocols because that is decreasing the HOXA10 expression and it is working much better as compared to the agonist treated patients. We know that the receptivity deteriorates during controlled ovarian hyperstimulation because we try to recruit more eggs, so that leads to a supraphysiological levels of the steroid hormones. This disturbed altered ratio of estrogen and progesterone will hamper the endometrial receptivity, as well as it also produces high E2 levels on the day of HCG, regardless the number of oocytes. That will also cause a derangement. So we have to be in a process, so we can upcome with the use of the step-down protocol, that is the FSH. It can be improved with the use of FSH step-down protocol. This decreases the estradiol levels in peri-implantation period, and also the studies have advocated the levels of E2 on the day of HCG with the step-down protocol were significantly lower. We also know that a damage is caused by elevated progesterone levels on the last day of COH, and it causes a negative impact on implantation. So monitoring the progesterone levels during the late follicular phase and taking the cutoff of 1.5 nanogram per ml becomes mandatory. Now, deciding a milder stimulation protocol, can we return to the natural IVF cycle? Can it be really considered? For me, I would say no, because the cancellation rates are much, much higher than in a stimulated cycle. Now, as we are progressing on vitrification front, this looks possible. One of the doctors here has already said he has stopped using the stimulated cycles and he's doing all 100% frozen embryo transfer cycles. Initially, the acceptance was not that good because the foremost in the belief was available freezing protocols used to cause a loss in the embryo viability, and that would negate any beneficial effect that would build up from the increased endometrial receptivity. But with better protocols and 100% retrieval rate, yes, we can definitely look this as a better alternative. To improve uterine vasculature is another strategy. But now I'll be skipping up. Most of the drugs has already been discussed in the previous lectures. Sildenafil was very nicely explained by my mentor, Dr. Purnima Madam. So I will just put a more light on arginine, which was not discussed. L-arginine has also been documented in literature. It is a substrate of nitric oxide, and it increases the hepatic and limbic blood flow. Nitric oxide release from endometrial cells leads to improved blood flow, and it can be taken in a very simple oral dosage forms, that is 6 milligrams per day. Basically, heparin was classically thought to improve pregnancy outcomes by preventing thrombosis during implantation and placental development in women with inherited and acquired thrombophilia. But it potentially modulates many of the known mechanisms that include the successful apposition, adhesion, penetration, and invasion of the endometrium. It also modulates the process of decidulization. Apart from what the literature has been saying, I have come across many patients, many files, many consultants. We have started empirically also using low molecular weight, considering that if you have not ruled out the thrombotic factor coming into and leading to recurrent implantation failure patients. Now you have to treat the pathological conditions appropriately. Luteal phase defect, it could be as per in the patient, or it could be iatrogenic. The thin endometrium, fibroids, intrauterine adhesions, endometriosis, uterine septums, hydrosalpinx, polyps, endometriosis, adenomyosis, PCOS, and autoimmune diseases. There's a long list of these pathological conditions, out of which the luteal phase defect can be aptly corrected with the use of exogenous progesterone treatment. Also, the use of HCG injections in small doses for the fresh cycles could be advised. Fibroids, adhesions, septums, hydrosalpinx can well be taken care of with good laparoscopy and fertility enhancing surgeries in the hands of a good laparoscopic surgeons. Apart from this, we have various agents and various procedures. We have not used them very frequently in the clinical settings, either because of the limitation of the cost factor or because of the limitation of the research being supporting these. So first is intravenous immunoglobulins. It's a fraction blood product, and they include the modulation of T cells, B cells, the natural killer cells, monocytes, and macrophages. They also downregulate the antibody production, inhibition of antibody function, and modulation of complement activation factor. But they are very expensive, and also they have a bit of life-threatening side effects, but in spite of that, in the literature, they had been widely used in the treatment of early reproductive failures. Intralipids, recent, much cheaper than IV globulins. Basically, they are known to act as an immunosuppressive, and the agent that is the effective of soya oil present in the intravenous lipid is the main ingredient that is known for causing the immunosuppressive effects. While the exact mechanism in which the intralipid modulates the immune system remains unclear, its active ingredient, soya oil, is reportedly capable of inhibiting the pro-inflammatory mediators, specifically the Th1 cells. Now, how do you infuse this? This is available in a pharmaceutical pack of 1 liter or also in a pack of 200 ml. Injectable Evil, a hydrocortisone vial, is given IV. Then you wait for 15 minutes. You monitor the vitals of the patient. Withdraw 5 ml of the 20% intralipid solution into the syringe, and then it can be infused into 500 ml of normal saline solution. It is given intravenously to the patient over an hour of 2 hours, with checking the vitals of about half to 2 hours. Normally, the first infusion is given 7 to 14 days before the planned embryo transfer implantation, followed by subsequent infusions on a positive pregnancy test and a first ultrasound scan. Decision on whether to give intralipids or IVIGs, they are based on the natural killer assay results. Allogenic lymphocyte therapy, then the recombinant human leukemia inhibiting factor, acupuncture, these are like when the consultant and the patient, I think both get tired, we don't get results, then we turn on, even before we turn on, the patients do turn on to the complementary and alternative medicines, which should not be discouraged totally. Acupuncture is known to influence the autonomic nervous system, and it could optimize endometrial receptivity in some extent. After oocyte retrieval, the cumulus, which is nearly discarded, was used along with the embryo transfer on the day of embryo transfer after incubating it by Dr. Firoza Parekh, and that was called as the cumulus aided transfer. This didn't gain much popularity because of quite unsuccessful attempts and lack of evidence in the literature. Local injury, this is very much debatable, and whether you can have a partial local injury to the endometrium by scratching just only the anterior wall or a complete local injury, but yes, definitely it has shown to improve the endometrial receptivity with better pregnancy implantation rates. The other physiological factors that should be modified would be the high BMI. It definitely demands correction, but everybody's complaint is whenever the consultant tells a patient to lose weight, the patient will definitely change the consultant. And smoking should be definitely quitted. We have, these are the very recent modalities, the endometrial receptive array. This is a genomic diagnostic tool for human endometrial receptivity based on transcriptomic signature. Now what is it? What is the goal in doing the ERA? Whom it can be done for, and do we really have advantages for doing this ERA? It is a specialized personalized genetic test to diagnose the state of endometrial receptivity in window of implantation. It is used to analyze the expression levels of 238 genes related to the status of endometrial receptivity. Now, when we do the ERA and we get the report interpreted is whether the patient is receptive on that day of biopsy or whether the patient is not receptive on the day of biopsy. In case we get a receptive day, we know when to implant the further embryo. But in case if we get a non-receptive report, they would, in the same report, they would suggest the another day to take the similar biopsy, and in the second report, probably they will give you the exact day of implantation. So basically it helps us in gathering whether the patient is having a displaced window of implantation, because of which the patient is going in for failures. So normally the biopsy is taken from the fundus during the window of implantation. Then you have to place the biopsy in the tube that has been provided by the company people and sent. You get the report in 14 working days. According to the interpretation of the report, you might get the displaced window of implantation, and that according to that report, you might decide the exact personalized embryo transfer day for that patient. The another modality of granulocyte stimulating factor, there were different studies. Dr. Anirudh has already included the whole genomics of how to use it, but this is a very simple slide showing once you have diagnosed the unresponsive endometrium 12 hours before HCG administration. So patient with endometrium less than 7 millimeters, you can go for G-CSF intrauterine perfusion 300 microgram. Normally when it comes with the pre-filled syringe, you can just overload it with a Tomcat catheter without touching the fundus. You can just go in for intrauterine perfusion. Reassess the endometrial thickness 2 days, that is the day of your pickup. If the endometrium is more than 7, you proceed with the further protocol, and if it is less than 7, then you might reconsider the second dose of G-CSF. Final endometrial assessment measurement on the day of embryo transfer, it should be more than 7. And this has been very highly documented. There's a very large study also conducted by Dr. Norbert. This was a very interesting case report in a single patient. This was a hyper responder, and 4 days just prior to that, before the HCG, this patient showed a very thin endometrium, bad endometrium with so much of fluid inside. But because the patient was given the option of retrieving, freezing, and cancelling the cycle. The patient, because of financial limitations, couldn't afford that. So she said, I want to continue. So the second option what she was given was, we will aspirate with a Tom catheter, we will infuse the G-CSF on the day of pickup, and then in case the endometrium is doing good, anywhere between more than 7 millimeters, we will go. So this patient, they aspirated on the day of HCG, they infused the G-CSF, and the patient was put on vaginal SDF 4 times daily and estradiol 2 milligram BD, and on the 4th day, what they saw, they had a good endometrium of 7.8 millimeters, and 8 weeks later, the patient was pregnant with a twin pregnancy. Well, we cannot get carried away by any of the single reports, but yes, definitely if we do try, our personal experiences with the evidence of literature can be put to the practical practice. What can the future really hold? The endometrial reconstruction from stem cells. At present, this is being under research, but this is specifically for the thin endometrium people who have been undergone surgeries for Seinecke, Asherman's syndrome. But if the endometrial reconstruction from stem cells is successful, it could definitely open doors for a better endometrial receptivity. This is my very favorite slide, which in short gives us the whole scenario of the factors on one side. According to the factors, diagnose the treatment spell to be done. If the embryonic factors, according to genetic, or whether the embryo is having an impaired development, what is to be done. This was basically for patients of recurrent implantation failure, but it also helps in really diagnosing and getting the factor treated. So because the endometrium sounds like a big orchestra, it has to have so many things during the process of implantation taking part, that is the anatomical, that is the physiology of the endometrium, the morphology, the biochemical factors, and so only when the symphony will be set right are we going to get a good implantation of a very good embryo. So in future, I think the focus of the future research should be on cellular and molecular aspect of endometrial tissue regeneration and prevention of formation and reformation of the post-surgical adhesions, which is a big problem at date. Local endometrial stimulation could be introduced in the future into the routine clinical settings, and I also believe that the endometrial stromal cells, adult stem cells, and gene therapy are promising options that can be effective in the future. Aristotle had said, the womb is the field of generation, and if this field be corrupted, it is in vain to expect any fruit, though it be ever well sown. Thank you. Thank you, sir.
I don't know what to say for intrauterine G-CSF. I have tried it on my patients having less than 8 millimeter of endometrium on the day of HCG, before the HCG trigger.
Yes, sir.
I have tried it in a number of cases intrauterine, and to tell you frankly, I have not got good results. But then when I started giving them subcutaneously, 12 hours before HCG and 12 hours after HCG, giving after HCG, the results were very fine. So I don't know what to say for intrauterine, but subcutaneously has definitely given me good results.
Yes, I would like to highlight here that when I started, I've just started it using since last 4 months. So, and I do my IVF in batches. So for the first 2 batches, I had used it as an intrauterine perfusion, and in the second, third and fourth batch, what I did was I just gave it empirically, empirically 3 hours before the embryo transfer, that is subcutaneous. So I had not even taken into consideration what was the endometrial thickness, what was the factor I'm treating the patient for. So, but definitely in that cycle, we got good results, but I think that data is still a bit less. So we need to have more and more numbers and figures to come to a positive conclusion.
I'd like to take advantage of being the chairman and make a remark.
Yes,
Okay,
sir.
so first of all, in my opinion, you might be surprised because I mean, as I see, I mean, a lot of people are using, I mean, colon stimulating factor and other stuff. Okay, so firstly, there was a recent review in Human Reproduction Update a few months ago, which I agree with, is there is no clear-cut limit for a receptive endometrium. There are, I mean, reports with, you know, pregnancies. I have seen personally pregnancies with 4 millimeters, and there's a report, I think it's from even India, for 3 millimeters, okay? So, and endometrial thickness itself, when you isolate it from female age and the number of oocytes collected, is a very poor predictor of chance of pregnancy. And this, I mean, not only granulocyte colony stimulating factor, but, you know, most, I mean, like sildenafil, etc., you know, there's no clear rationale, you know, biologically plausible rationale behind these practices. And they usually, you know, the initial reports usually come from a few well-known groups where, you know, other people have difficulty in replicating their results. So, I mean, Norbert Glacher himself recently published a trial, you know, that you, I mean, the first speaker cited. It seems to be ineffective if you give it across the board, okay? And basically, I've been using it too out of desperation in my patients until last year. I wasn't suggesting, I was just discussing with the patient. I mean, there's a patient, you know, who has this repeatedly, you know, thin endometrium. You know, they look for a solution. You discuss, then you say, you know, this is, I mean, it's not inexpensive. It is. It is expensive. It's expensive. And I mean, when you instill into the endometrial cavity, you can hope maybe, you know, it would have less systemic effects. But I mean, when we're prescribing anything that deals with the immune system, you know, there is a risk to harm the patient as well. Okay, so I think we really need good evidence before, you know, like starting giving people, you know, subcutaneous or, I mean, systemic, you know, I mean, medications that affect immune system. And same goes for intravenous immunoglobulin. You know, it became popular with recurrent pregnancy losses, and just a few months ago, I mean, Dr. Anderson from Denmark himself presented his results of a randomized controlled trial, even in recurrent miscarriage. The strongest proponent of this treatment was very disappointed that it eventually proved ineffective without any doubt. So I am kind of, you know, I mean, I am personally, as long as I rule out endometrial adhesions with a 3D saline or a office hysteroscopy, I personally don't bother with endometrial thickness. And I'm not saying what I'm doing is right, but I mean, I'm not using any of these medications.
You'd not like to use it empirically until
not at all.
Thank you, sir.
So why I said this was, I don't mean the results of pregnancy, getting pregnancy, but the results of the endometrial growth were dramatically different when it was given intrauterine by me and given subcutaneously. Dramatically different. I don't know why, but I don't know whether anyone else has observed this or not, but when it was given subcutaneously, the growth was about 2 millimeters, and I didn't get any growth when it was given intrauterine.
I want to talk about my experience when we go through literature, when something happens, and if I have to write an editorial or a review and we go through literature, we sift out. There are anecdotal reports and then there are randomized controlled blind studies. Actually, you all should all go back after the conference, and I was in 1996, I trained for some time in Chicago in a place called Center for Human Reproduction, CHR. And at that time, only that center got results with IVIG. I don't know if you remember, if you see the thing that time, 95, 96, 97, IVIG was suddenly thrust upon us with publications that it works, but it never worked with anybody else. 10 years later, they came with DHEA. It's never, at least with large numbers, there was a time when we were doing something like, with many centers, 700 cycles a month I was doing transfers. DHEA has never worked, never, ever. Only androgenic side effects started. And now, that same group has introduced G-CSF and it only works for them. You know, sometimes I wonder that all these path-breaking things come and it only works for one particular doctor. That is not science. I feel that yes, vitrification now works, is easily replicable. Everybody is getting high pregnancy rates with the freeze-all or whatever. So that is science. All else is like the Indian masala theory. I do this and IV and rectal and everything, and we don't publish. So when we talk internationally, we have really no face. We give anecdotal experiences that we had good results. But I feel that the youngsters now are doing, there is a degree, you know, the national board has done, we should publish. We should aggressively publish. This is an appeal from me that we have launched this journal with great difficulty and great opposition, this Journal of Minimal Stimulation IVF. That is, we are accepting papers from IVF, it's not minimal stimulation. So Percy, if you have even 8 patients and you have given subcutaneous, the world has never read this. So you send it to me, we will peer review it, send it to 2 good people, correct it, push it, see that it is published from India, so that then there are others who will write to us, give their experiences. So I feel that all of us here, this conference I have seen that people are listening, and so if we are listening and we have few patients that we are doing different things and it works, please document and send it to us. It's ivflight.org. You can upload the papers and we will put it, we will not take shortcuts. There will be no back scratching. Somebody calls me up, like I'm Foxy president, and take my paper in. I'm not going to do it. It will go through the peer review process. But please do it. All this, I'm fascinated that, you know, by Percy's description that he gave it subcut and he got dramatic improvement in. So without adjectives, if you have pre-infusion photograph, ultrasound plate and a later ultrasound plate, even for a couple of patients, it's enough. We will publish this. So I feel that use this conference as people like Baris are always willing to help, guide. You know, before you submit your manuscript, you can send it to him, me, we can guide you, but please publish from India. That is the only way we will get respect internationally.
Gautam, one of the companies, I'm sorry I'm giving the name VHB, which is giving it as Newfill, they've written that you can give it subcutaneously. They've written it in the literature and on the box also.
Subcutaneously for what indication?
For the same indication of...
this is an off-label use. It's not FDA approved yet.
And even I was surprised when I gave subcutaneously.
It is just like the grey zone of letrozole. Letrozole, what we were using for ovulation induction, was an off-label use. Newfill for refractory endometrium is an off-label use. If it works.
And I personally would not recommend Newfill. I don't have anything against any pharma company. But the thing is, when they had come to detail me the molecule, I had asked them for a product monograph. So they didn't have a product monograph. I think a molecule which you are introducing and asking for general public use, you should at least have a product monograph for that.
No, they will.
So I discarded, the day a company guy, when he was, he met my demands, he gave me the product monograph only after the reading the whole thing.
I want to make this very clear, Percy, you have a very wrong, this subcute thing is for
even I'm telling you, everyone is using it intrauterine. Everyone is, even I was surprised when I used it.
Intrauterine is an off-label use. When this drug was introduced into India, the phase 3 clinical trials that were conducted were for medical oncology. And this G-CSF use has come after Norbert Gleicher's paper. So this is an off-label use, just like we were using letrozole for ovulation induction. So I feel this is brilliant. Like if we get something from Europe,
I was myself
and you all
surprised
can do,
when I saw it subcutaneous.
No, but if you can, you know, even publish it together and have 15 patients, I'm telling you, the world doesn't have this experience. It will get accepted. Yes, so you must send it to us. We will, you know, ensure we can.
No, I don't have any 50. I only 10 patients. I don't have this record for 50 patients.
No, Percy, but you are not.
But I have tried it on another 10, 12 patients intrauterine also at the same time.
I'm not consider, even if there is one patient and you have documented it, I'm saying send it as a short commentary, case report, but publish it, but with ultrasound plates, dated ultrasound plates, because if it comes for scrutiny, when you are presenting it in Europe or the USA, they are going to ask you, you know, for supportings. So I feel that once we are clear, we should publish this data. Maybe this is a new science and really it helps, and all of us next 2 years later when we do the next WOOSP, we'll have many other people coming with published reports. So let's not get into companies. We publish. If you have the science, please publish it. ivflight.org. Please upload it. It's a very simple automated process. And it will be unbiased. It will go to 2 peer reviewers. Based on their comments, they will write back to you to correct it, modify it. And within 3 months of submission, it will be published.
I mean, not only thickness or pregnancy rate also.
Yes, whatever your endpoint you decide. If for one paper you can just have G-CSF and endometrial thickness as the endpoint, another publication could be pregnancy rate as the endpoint. You can have 3-4 publications from that data. So I feel that do it fast before somebody with 3 cases from Germany does it.
This regarding GCF. One study I read that it is useful in LURF, provided it is given subcutaneously. I do not know what is the mechanism.
In what?
The LURF, the cases of LURF, this GCF injection to be given subcutaneous. I do not know. Mechanism, if anybody knows, I would like to know how it acts.
There is very little good published literature. Today there are open access journals that are accepting trash. So I feel that it has to go through a peer review process, get some results. In the next 3-4 months, we are going to have a lot of publications coming up. So if we have early experience, we should publish. So